Thank you, and thank you to the organizers for inviting me. So as Ben said, I'm definitely happy to answer questions or talk with you throughout the next 2 days. I don't always have the answers, but at least I can give you my opinion, and I feel like the more we get people talking, the better we'll have solutions. So feel free to find me throughout the next few days. So I was given the task of talking about goals of rehab, restoration versus maintenance, and how we all have to kind of work together. And I think that's the meet us halfway part of this. And I'll give you a little bit of my background. So I am an occupational therapist from way back. And now I do more research than therapy, but I find it's really important for me to have my hands in both, because seeing the patients is where I often get many of my questions, where I really figure out what the needs are, and then I try to use my research background to try to get at the issues that might be more important for people to continue living their lives and have a good quality of life. So I'm going to tell you a little bit today about a little bit about my research, which is the first couple. You're going to hear a lot of other intervention studies that will be discussed later this morning. Then I'm going to talk to you a little bit about what I feel like are important goals for rehab, kind of address what maybe you might choose to be your goals for rehab, and then end with something I call critical thinking, which all of us, me included, I feel like I always need to be reminded about this, and then I'll take questions. And if you have questions throughout, please just raise your hand. So a friend of mine said, "You're not really going to start the talk with a cartoon, are you?" So I know this is what everybody does, but I feel like this kind of describes what we want, right? So whether it's with a pharmacologic modality or in a rehab intervention, we just want to be able to restart and start over. And the reality is that doesn't exist, but there are ways that we can piece it together to be able to get a restart or be able to improve. So you'll hear later this morning different rehabilitation options, and it's really important to be educated on the different options that are out there and recognize that they aren't all for everybody, but knowing who's the best, what kind of intervention is the best is really important. It's important for you to have your own rehab goals, and it's important to make the right choice. So there are goals to maintain function, and there are goals to restore function. And regardless of what disability or what condition we have, we all should have those kinds of goals. The questions that I think are needed to address really is, how do we know which interventions are best? And do we know which interventions are best? So that's part of what I'd like you to keep in mind as you listen this morning. So which interventions really are for what kind of individual? Because I think if we can specify that, that will solve many of our issues. Rehabilitation research is a little behind pharmacologic research for finding medications. And I think that's in part because we need better outcomes, but we also need patients to be talking to therapists and researchers. We need to have this communication, like symposiums like this, to really understand what the real issues are. So my research, I find myself going back and forth between understanding structure, meaning kind of pathology, how that changes with different conditions, and function. And by function, this is a very broad category. I have a laboratory where I focus more on balance and walking, but as Ben said, that isn't the issue for everyone. And so I'll encourage you to sort of broaden this, even though my talk will be more focused on walking and balance. But we need to be able to go between these two categories to assess better and to be able to be predictive, to know which interventions would work for you better than someone else. So I try to link structural disease pathology to function, and I do this by trying to bridge this gap by measuring impairments. And by impairments, I mean things like strength and sensation and balance and walking, but also using MRI in a creative way to try to get at the health of the different pathways that carry that information to our muscles to allow us to move. And so ideally, I'm trying to find a scientific way to understand walking deficits. And I think in rare diseases and just complicated diseases, this is a really important, rather than just doing trial and error, which is often what's done to understand function, we really need to have a rationale that leads to where the pathology started. So this is just another way of saying it. So I use MRI to look at the spinal cord in detail. I measure impairments in the lab. I try to use analyses to get at specific features of the MRI, and then I look at walking. So I'll tell you sort of the obvious fact, right? The spinal cord is small. It's about the size of your thumb, about 1.5 centimeters from right to left. And relative to your brain, It's a very small part of it, right? So everything from our brain, though, funnels through the spinal cord to allow us to move our arms and our legs. So you can imagine that a small lesion in the spinal cord is going to have a much bigger impact, right? Versus having a small lesion here, there might be areas that could sort of cover the function of the area that's damaged in the brain. In the spinal cord, it's much harder to have that happen. So part of what I've done is I was looking, if I just look at a slice of the spinal cord, so this is as though if you cut my spinal cord here and then kind of laid it out for you to see, this is what you would see. This gray part should be more uniformly gray. This white part is this cerebrospinal fluid around it, and this is the bone here. And so what you see, these white areas are lesions, and they're in a particular area of the spinal cord that is important for strength. So I wanted to know, it seems obvious because we know this should be related to strength, but no one had ever related an MRI measure of these particular areas to strength. So that's what I did. I brought individuals in who have multiple sclerosis, I measured their sensation, and I compared them with healthy controls. And vibration sensation is really important for us to be able to maintain our ability to stand. We get a lot of information from our feet to know where the ground is, if we're stepping on something, if the ground is flat or sloped. And I also measured strength. And what I found is that for this particular individual, their sensation was normal, but their strength was very weak. Now compare that to this individual who has lesions here and here. And what I found is that their sensation is worse than controls, and their strength is weaker than controls. So it seems obvious that this relationship should exist, but we really need to be careful to know that it needs to be quantified, and we need to be able to prove that, and that's where research comes in. I'm also running a study, an exercise study, and so what we're trying to do is be predictive. Could I know, based on pathology, based on your MRI of your brain and spinal cord, could I know that you're going to respond to an exercise intervention? Now, I picked exercise at random, so there are lots of different interventions, but I felt like I've read a lot of studies that say, of course, we should be exercising. Of course, you can gain strength if you exercise. But as I read more closely, I found that actually in some of the studies, there's a percentage of people that don't get stronger, and then they're not discussed. So the study, the author focuses on, of course, the success of who did get stronger. So my thought was maybe if we use MRI in combination with what I can measure in the laboratory, could I better understand who would be able to get stronger? Is there something different about their pathology that would lead us to that? So I bring people in, I test them. A pre-test would be using the MRI, measuring in our lab strength, sensation, walking, balance. Put them through a 12-week exercise program that's tailored to their needs, and it's run by a trainer and a physical therapist. They come in 3 times a week for 12 weeks, and we're very vigilant that they don't miss exercise sessions. And then they come back. At the 12th week, we go through, we don't give another MRI, because the idea was, could I use the MRI from here to predict it? So the idea would be, would I know who should get that kind of intervention? Can I predict that? And so we're in the middle of the study, and I don't have answers for that yet, but the idea is, can we link information from an MRI with this more practical information that we get and that you all feel when you move? So it combines a clinical evaluation, imaging, measures of impairment, and measures of disability to provide a more precise prognosis and predict who is likely to respond to a physical intervention like exercise. Another study I'm using is using something called transcranial magnetic stimulation, which you'll hear about later in detail. And I'm only bringing this up just to tell you that there are a variety of studies going on that are linked to function and to rehab. So what this intervention does is I can provide a stimulation to a part of the brain that we think carries motor information, and then I can measure at the hand or at the leg the muscle, and I can remeasure the response after that stim. And the idea is this type of tool can help us evaluate how healthy that primary motor pathway is, the pathway that's critical for us to use our muscles. Now, I'm linking this with a drug that we know in people with MS improves walking in a percentage of those of those people. So this drug is Ampera, which I'm sure many of you have heard of. And essentially what it does, this is a neuron. These are little blocks of myelin, and myelin is lost, and so potassium leaks out of that neuron, and that makes the action potential that carries information to the muscles be slowed or stopped completely. And the drug, what it does is it kind of plugs up some of these holes, so less potassium leaks out. And we think that's why when you take this drug, now you can walk faster. Now, it's only about 20% of the people that take the drug in MS, specifically for MS, will have improvements in walking. And it's never been looked at in other diseases. So we're studying this in transverse myelitis. We're going to use transcranial magnetic stim, the stim I told you about, to determine how effective this drug is in people with transverse myelitis. Yes?
When you're looking at Ampera, have you found, of any of the studies showed whether people saw a sort of improvement in the first 6 months, but then it tailed off? Because a lot of people that I've spoken with, that's been the case. I just wondered whether that was...
Yeah, good. That's a good question. So the question is, do people that feel a response or improvement when they first take the drug, does that taper off over 6 months or even go away? And I've heard this many times in the clinic that patients are saying, well, I felt an effect when I started it, but now I don't know if there's an effect. So I think the jury is still out, but I will tell you from an anecdotal standpoint, some of these people with MS have gone off Ampera and then noticed that they do walk worse. So it may be that you don't notice the benefit you're getting, but it does keep you at a level that's more functional. But it's an important question. These are exactly the kinds of questions that we need to be asking your healthcare providers to give you. Okay. So this is just to give you an idea of the protocol. So essentially they come in, half the group gets the drug, half the group doesn't. Then they're crossed over so that the group that got the drug originally now doesn't get it, and the group that didn't get it in the first place now gets it. This is probably the fairest way to give everyone an opportunity to be on the drug and still let us, the researchers, determine what the effect is. So questions we will address will be, so will this drug improve walking speed in people with TM? Can we predict who those responders are so that we don't have to put them through taking a drug that might not be effective? It's also a very expensive drug. Maybe there are more responders in TM than there are in MS. What physiologic features are improved? So this might lead us to who are the best responders. And importantly, so what actually improves? Is it really just walking speed? Is there something about the quality of how they walk? Is it just that they feel like they can do more, and so they're able to use their limbs, not just their legs, better? And which clinical characteristics didn't improve? Okay, so I've kind of yes.
I have a question. Do you have any reason to expect that this drug would improve other functions, like upper extremity function, not just walking?
Yeah, very good question. So is there any reason to think that this drug could improve upper extremity function, for example, other than just walking? So it's important to recognize that when you take a medication, it's a systemic medication, right? I'm not just targeting the neurons that go to your legs. It goes everywhere. And in part, that's what makes it frustrating, right? Because it makes it a little bit less precise. But in part, it might lead to other effects. So definitely, it's possible that upper extremity function could be improved. We also don't know how much of, how many healthy neurons you need in your spinal cord to be able to maintain your walking or to get stronger. And so that's part of why using a physiologic measure like transcranial magnetic stimulation could give us a little bit more of that information. Yes?
What about the patients who cannot walk?
Good question. So what about the patients who can't walk? Would they derive any benefit? So a similar response as to upper extremity function. You would think that if the drug is working by basically closing up some of these gaps that have been damaged, that you would see improvement in other ways. So maybe the person who couldn't walk now, they can use their legs better and can stand longer. Perhaps it would improve their arm function. Perhaps it improves their trunk control. So really, they're all unanswered questions, but really critical. And this is why we need, even if they're just small studies to start with. So we're doing this study and we're trying to study 20 people with TM. And so it's small, but at least it would give us an anecdote of whether we need a bigger study or whether we need to just inform clinicians that this could be tried. Another important part of having a study is that we could get insurance companies to pay for the medication for this particular disease, because right now it's covered for MS, but not for other things. Okay. So in addition to outcome measures, so that's my emphasis so far has been we need to be able to measure that there is an improvement or not. But we don't know other things about interventions as well. So I bring this cartoon in because I think it's interesting. The physician's saying, so the handle on your recliner doesn't really count as the exercise machine. And it sounds really silly, right? But it's important because the way we do the intervention is critical, right? So you can count anything as exercise, but is that the kind of exercise we want, right? Another thing that I find interesting is we don't really know much about the dose. So they're saying, we can combine all of these into one convenient dose, which is what we all want. But the reality is rehab is really hard because we're asking you to work hard for not just the few minutes you take a pill or you get an infusion, but really you need to work hard for an hour. And then you need to keep trying all the time to get up and move and do more. And it's challenging. And the fact that we can't even get the average American to exercise regularly should be telling, right? So now we are asking people who have even more trouble moving to exercise regularly. So we need to be supportive of one another, but really figure out what the dose is that we need. We don't maybe need an hour of exercise. Maybe we really just need to focus on certain muscle groups. And these are the questions I'll get to next. What kind of information about dose do we have? So this is basically what I just said. Are there details or circumstances that are really important for an intervention to work? So I'm going to talk to you about a study that's done in the lab. This is done actually with healthy individuals. We just wanted to know if we put you on this treadmill that is kind of novel in the fact that it has two separate belts. So you walk in a treadmill, it's one belt that you walk over. This has two separate belts that are run by separate motors. And you might think that's just a contrived, not very practical device. But if you think about what happens when you go around a corner, one leg has to move faster than the other. If you think about stepping over objects, one leg takes a bigger step than the other. So this use of a treadmill with two different belts has actually very practical, obvious implications. The way we used it, though, is we just wanted to know if we take your average individual, walk them on this treadmill, and make one belt go faster than the other, how long would that generalize? Can we actually change their walking pattern? And is that information saved somewhere in our nervous system for the next day? So I'm going to show you some videos here. So this is a person, even though it looks like a blob here. And the left leg, the yellow leg, is going to move at a different speed than the blue leg. And you're going to see down here a measure of the angle of that hip as it goes through each step, okay? And this is when we first put them on the treadmill. So it's an obvious limp, right? The blue leg is taking a much smaller step than the yellow leg, right? Now we keep them walking on the treadmill. Don't change anything. They know that this is happening, right? That there's two different belt speeds. Now 15 minutes later, interestingly, now they're taking the same steps. So the belts are still not going the same speed. So we've adapted our walking characteristics to walk more symmetrically. Now, we asked, so great, go home, do whatever you normally do, and then we're going to bring you back the next day. And do we see any savings of that information? Or is it gone because now you've walked over ground for 24 hours? Oops, hold on. And what you see is it is saved. So actually, there is savings. This information is saved for the next day. The way we measure this is a measure of step symmetry. So how closely linked are your left and right legs? Do you take the same size step? And so day one is in blue, and the x-axis here is step number or stride number. So you want to be up here as high as possible, and that means your legs are moving exactly the same. And you'll see that when we first put the person on the treadmill with the split belts, they have very unsymmetric walking, but then over about 150 steps, now they can walk more symmetrically. They never get exactly to zero, and we found that actually in healthy people, we're not exactly symmetric. The next day, they actually start here. So they're not starting way down here. They already use some of that strategy and can get up to this symmetric level much faster. So this is kind of useful information for a therapist, right? Because we're trying to say, come into therapy for an hour. We want to work on some things. And then come back in 3 days. And sometimes I'm like, I don't know if they're going to remember, if their central nervous system is going to remember any of that. And now we have evidence that it does, at least in this particular paradigm. Another important question is, do we care if you walk symmetrically? So why do we spend so much effort trying to get people walking around with a symmetric pattern? So a postdoc in our lab asked the question, can we just measure how efficiently people walk when we put them on this split belt treadmill, and does it have any relationship to how much energy you use to walk? What I'm going to show you is that this is more symmetric here, and this is the reduction in power. So how much less power did you need? How much more efficient? So what I'm showing is that the individuals that walked more symmetrically after being on this treadmill used less energy. Not surprising, it might be really obvious to you as the listener, but again, we need to be able to prove this in a rehab, in a study, to know how to get to the next step. When the central nervous system isn't healthy, how important is this? Okay, the last study I'm going to bring up is we ran a different study, and we said, okay, I want you to take an exercise program home with you. This is for people who have a different, very rare disease as well, cerebellar degeneration. And we said, bring this exercise program home. We're going to train you exactly how to do it, and we want you to do it 4 days a week for 30 minutes. And so I don't know about you, but when I start this in my head, I'm thinking, right, so I'll do it, patients will do it for about a week and then it'll drop off. And we said, come back in 3 weeks and we're going to update the program, and then we're going to let you do it for 3 more weeks. And so it turns out that many of the features of walking improved because patients did the exercise program. At least they documented that they did it. But the most important feature wasn't really the number of the hours they spent on it. The most important feature was how challenging the exercises were. So the people that reported that the exercises were really hard to do and they struggled with them a lot, those are the people that made the best gains. So this isn't surprising either, right? So we know that when you work the hardest, you make the best gains. But this needs to be taken now into a rehab context and say, it's not just, for example, exercise that does it. It might be the exact kind of exercise, the right muscle group, and the right kind of emphasis, the right kind of challenge to each person that's really critical. So this is sort of a laundry list of things that I think are really important for what we need to do to understand how rehab interventions work. So we need to understand better how important walking symmetry is when the central nervous system isn't healthy. How much practice do we really need for a rehab intervention to be successful? Is strength training more important than the number of repetitions? So that's critical because fatigue is often an issue, right? And you want to lead your life as well as go through this rehabilitation program. So we need to know how many repetitions or how long people need to do certain things. Is it the length of time walking that's more important than the number of steps? Because if you walk slower, you get fewer steps in. But maybe it's just you need to get to 100 steps, and that's when our central nervous system sort of figures out the new pattern. And then this last one I think is really important. How do you stay focused on an intervention to keep it challenging? Because for myself, even when I exercise, I can go to the gym and I have sort of a standard thing I do, and I'm busy and I'm tired and I'm glad I just made it to the gym, so I just kind of do the same thing. And then I realize I'm not really making any gains. So you have to keep it fresh. You have to keep updating it. And that's where your rehab professionals are really important. So even if you feel like your therapist doesn't give you new things to do and it's not really reasonable to go 3 times a week for 6 weeks, maybe you devise a new program. Maybe you say, I'm going to come every 3 months. I want you to reevaluate me and just tell me what's new and update what I'm doing at home. It's a little unconventional, but insurance would pay for it, because it's not an overuse of the system. It's just a matter of staying more focused on updating what you're doing now. So what are your goals? So what are the important goals that you want from rehabilitation? I want to sort of end with this idea of critical thinking. So I think it's really important that we all read some literature, but more important that you talk to your physicians, your therapists, your friends, and talk about what things work for you, what don't work, and be really aware that your ideas on what works and doesn't work, whether you're a trained professional or not, really matter, because you might be feeling it totally different than I'm experiencing it by telling you what to do. So if you read an article and you found that one treatment is found to be very effective, I want you to think about a couple of things that are really important, because there aren't a lot of studies for these rare diseases like TM or ADEM. But as Ben said, we can really borrow information from other diseases like stroke, like MS, and because rehabilitation is at a stage where it's still very general. So I think it'd be great if you can read about a treatment, realize that it could be in a small select group with a single condition, and keep that in your head, that this is for someone with MS, which is really different than TM, but maybe I could benefit from this. I want you to read about how effective it is in those people, realize it's probably not even tested in TM, and then bring this to your professional, bring this to your physician or your nurse or your therapist, and suggest it, because I think this is why I really like staying in clinical practice, is I feel like I need ideas for what you think is important, what interventions you read about. And try to ask yourself the question, does a person with a similar condition try this treatment? Does it make sense for you, for whatever condition you have, to try this kind of treatment? It might not, and that's why you bring it to someone who has more training, and they can describe for you why it might not make sense, but it might, and that might be the next step that we need to bring us closer to really solving this problem. So consider also the risks in any study that you read about. How similar is the condition that you're reading about to the actual, that you're reading about to your condition? How does this intervention affect your whole life? Is it worth the effort you're gonna have to put out? And this last one is important, so be careful of the sales pitch, right? So there are a lot of interventions that may work for one group and haven't been tried in some of the rare diseases. Make sure it makes sense to you and makes sense to your healthcare professional before you jump into it. And I'm gonna end with, what are your goals? Even write them down. Try to keep track of what is important to you, and tell people that, and that know that that's your goal of what you're trying to do. And there might be long-term goals and short-term goals, and that would be the most rational way to do it. And temper those by discussing these goals with your friends and family and your physician and therapist. So that's where I'm going to end. If you have any questions, I'm happy to take them. Thank you.